Thank you so much, and thank you for giving us the opportunity to participate in all your knowledge and to share some ideas here. And when you speak about that you're scared about this tibia leveling osteotomy, I think finally we feel we grow a little bit, because that's really this daily procedure that we do as an orthopedic vet surgeon. So we're happy to help. What we speak about, what I want to speak about today is our internal brace experience in distal extremities in dogs and cats, where it comes to really small dogs and traumatic injuries that they suffer there. I don't think any of my disclosures will affect what I'm telling you here. And the distal extremity or internal brace experience that we have is probably mainly in the Carpus and the Stifle and the Tarsus. And I want to go through our experience why we think these are challenging injuries and how we try to manage them with the help of this internal brace technique. So what we have is typically very challenging patients. So the most reckless athlete that you can imagine is probably something that we have to face, combined with a client or an owner of the dog, that we also have to convince that he not only has to commit to a rehab program, but just kind of commit to an exercise restriction program that enables our repair to be sustainable. We also see challenging cases. This was a cat, I'll come back to that later, that had a bilateral multiligamentous stifle injury. Because of these challenges that we face, many of the vets, they basically just do a repair that is probably not strong enough, and in order to protect their repair, they just put an extra-articular frame on top of it, basically to let biology work. But of course, biology will work in the way that it will basically destroy the joint. So of course, that ligament or that instability in the joint, and this is a cat's ankle, is going to be stable, but the whole joint will have lost all its range of motion. So of course, your repair is going to be successful, but the price that the animal pays is devastating, coming back to osteoarthritis or degeneration of the joint that is probably accelerated by this immobilization in the long term, but also in the short term, with complications of these extra-articular frames that can lead to short-term, even fractures with these extra-articular frames. So starting from the ankle, this is a cat's ankle, a 3D reconstruction from a CT. We try to develop a strategy to basically reconstruct as anatomically as possible the parts of the medial collateral ligament in the cat. And this is the two strands that basically this medial collateral ligament consists of. And we saw two challenges. Basically, one is that it's very small, it's very tiny bones, and on top of that, they are extremely brittle. So when you try to insert some implants, either a fast tack or an interference screw like a push lock, what can happen is that these brittle bones, they basically just break, because they are not made to harvest the smallest implants that we can find, but also the bone is not capable to basically harvest it. And so what we first did to basically try to test our two reconstruction techniques, we tested this push lock and the fast tack screw. Excluded, of course, the fast tack, because 50% of the bones, they already broke when we inserted the fast tack in the talus. And we defined with a CT scan the ankles that you really need to respect to be able to insert these implants in these small bones. And as you can see, this is in a sagittal section the calcaneus of the cat. This would be our point, distal anchor point of the oblique part of the collateral ligament, and this would be the anchor part of the long part of the collateral ligament. Be aware that this is drill canals that are about 2.4 millimeters in size, and the smallest anchors that we found that we could use is the push locks that have 2.5 millimeters in size. And it's just about what this bone is able to take. And imagine also first the diameter and second the length kind of limits us, because once this ankle gets too long, you might end up into a next joint space and having issues there. What you saw on the image before, we tried to be also from the origin, from the footprint of that short collateral ligament, as anatomic as possible. But as you see in this picture, excuse me, the footprint is basically, this is a picture from the distal side of the joint surface of the tarsus of the tibia, and this is basically the footprint of the medial collateral ligament. So to be able to be really anatomic in our reconstruction, we try to use a little bone canal to shuttle our ligament, our brace, and to anchor it then basically more proximally in the tibia, where we have more bone stock. Typically these injuries are traumatic, not as Antonio presented, degenerative. So we try to resuture, same as the principle that you taught us, to do a primary repair, but typically it's very difficult. So the brace that we put on top needs to sustain a lot of strength. And we actually tested this. So this is again the repair, having the two push locks here in the talus and here in the calcaneus. Here the shuttle canal, and here basically an intermedullary button that anchors our reconstruction on the proximal side. And what we see here in this biomechanical testing, this the measurement of the elongation. So longer is in this case less good, and here you see the intact ligament. Here you see a typically used tunnel technique, so there was just some sutures shuttled through bone tunnels and then knotted. And here our knotless technique that you see here, and you see the tunnel technique is far less stable than, of course, the intact, but with our reconstruction, the knotless reconstruction, we were able to, in the initial stiffness, be quite as good as the intact version, to basically justify a castless repair, so no post-op immobilization, basically only relying on this initial strength, and also enabling very early return to full function, and not to need to restrict the animal. This is a video that is immediately post-surgery, so 12 hours after surgery, obviously still limping cat, and this is 3 months after surgery, the cat already roaming free, and this is the appropriate control radiographs. Moving to the carpus, another joint, distal extremity that is quite often injured. And you see here some medial instability, here the radius, here the radial carpal bone, and here you can also appreciate a small fragment, probably an avulsive fragment, that also would maybe enable us to do a primary repair. What often happens in these injuries is that there's a question of palmar instability, and this is very crucial in animals because they walk on their toes, so there's a lot of force acting on the palmar structures on the carpus, which some of the surgeons leads to the decision that they immediately do an arthrodesis because they are afraid that the repair might in the end fail. And to investigate this, we did a study to basically look at the anatomy and check the use of MRI to really locate the injury precisely if the palmar apparatus is also included, or if it's really only the medial or lateral collateral ligament that is severed. That would then enable us to do a primary repair on top of a bracing technique. So this is a case that I wanted to share. This is some intra-op pictures. You saw the radiographs before. This is the intra-op view, and the avulsed fragment even had some articular cartilage included. Here I tried to do a little bit of compression, of course very humbled not to break it, and I secured it with the 2 K wires, and this is two K wires just to with a minimal invasive way distally to be able to find my landmarks where to put the bone anchors to finally then secure the brace. So this would be my primary repair, having here this small piece with the avulsed medial collateral ligament secured, and then on top you see here the canal of a 2.9 push lock, and this of a 2.5 and a 2.4 push lock to basically secure the brace to span all the medial collateral ligament on the medial side of the joint. Unfortunately, this dog ended up in infection, so I had to remove basically Antonio had to remove all my implants. This is a similar case with a 4 weeks follow-up, and this is a video that is hopefully showing. Yeah, there it is. With the animal back to full exercise and running happily after his ball 3 weeks after, 3 months after the surgery. And then finally, this is this cat that I showed you the images before, that came home, and the client reported some strange gait. And then you can immediately realize there's something awkward happening in the hind limbs. And this was the appropriate radiograph, so really a bilateral multiligamentous stifle injury. Rarely that we see this in both hind limbs, but kind of frequent to have it as a traumatic injury in cats. And the cruciate ligament in cats is typically traumatic. So that's different from what we see in dogs. It's not degenerative, it's not a partial tear, it's typically really traumatic, even up to multiligamentous injuries in the stifle. So also here we try to develop a technique to make it really strong, to avoid this post-op rigid immobilization, and to enable the animal to walk early and to regain full function of the joint. This is the reconstruction. We have a medial collateral ligament reconstruction. We have an extra-articular ACL reconstruction. And as we had some failures and we did not reconstruct the posterior cruciate ligament, we added an intra-articular reconstruction of the caudal cruciate ligament. We're finally writing these cases up, and we're really very happy with the results. This is the same patient 12 hours after surgery still, probably not as functional as it's supposed to be, but here for suture removal already happily watching the next cat coming into the examination room. And this is a friend of him that only had a unilateral injury that is 3 months after the initial trauma, that is back to, as far as you can tell, comfortable stretching and normal activity for the cat. And yeah, I'm already at the end of my talk. Thank you very much for sharing this with me.